بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, it is my pleasure today to invite our brother, Al-Ustad Professor Dr. Hisham Al Sayed. Really, there's no enough introduction to introduce Hisham apart from saying that he is a well-known figure throughout the world in the nephrology department and general medicine at large. Hisham really one of the leaders, not only in the region but worldwide, in our nephrology care of our patients throughout the globe. Of course, Hisham has a long history of educational and research, as well a lot of my publication, and it is today our pleasure to give us a tipping scales really about the mechanism of the understanding of chronic diseases. And without any further ado, the floor is yours, Hisham Habib. تفضل.
بسم الله الرحمن الرحيم. السلام عليكم جميعا. Thank you very much, my dear friend and brother, Professor Isa. And thanks for all of our colleagues. Really, it's my honor to be with you and all of our ambassadors in Oman from the Egyptian Society of Nephrology and Transplantation. We are very proud that of their activity. And thanks again for addressing me this very hard topic. Actually, I will try not to be bothering you by many of information. I think it will be some like messages because each slide needs a separate talk. So we have here what's here in actually in dialysis. And if you are looking for a very comprehensive hemodialysis agenda, we need to focus right now for dialysis session per se, meaning that we are looking for the 4 hours of dialysis. By all means of caring of patients during the dialysis session. However, for caring of hemodialysis patients, we need 2 dialysis days and the non-dialysis days. We have to look for patients' educations, patient nutrition, fluids balance, and medication adherence, as well emotional and supporting groups for all. For this very tight paragraph showing that we have to take care of all our patients in many of the topics, not only on the dialysis. But however, this session will be talking about one of the behind the scene, what's happening during dialysis and usually asymptomatic for the patients. So we have to look for, not for symptoms of the patient. And if you look for my agenda here, we have 4 pillars. We will focus on some of them and we will cancel or highlighting only few of them. So we have many pillars like membrane contact and the bioincompatibility. We have to look for dialysis fluids, compositions and the contaminants. We have to do unphysiological dialysis, how to match the real kidney function. And what dialysis does not remove, which is the uremic toxin retention, meaning that the larger molecules and the protein bound. And the microvalence is الشر الكبير inside the dialysis that passed unmasked in some cases and masked in many of cases, like complement, neutrophil activation, and netosis. We'll highlight this in the slides. Like endotoxins, not only from the dialysate, but only can cause from patients itself from the gut, which is the gut-renal axis. Tissue hypoxia, hypovolemia, and the hypervolemia. Loss of dialysis because dialysis is blind, so there is many of antioxidant loss. And then looking for the systemic effect, what's called sterile inflammation, not meaning that bacteremia, endotoxemia, ischemic insult for many of the organs. So this is my agenda. I will focus on the sum of the pillar, not all the pillar, but highlighting many of them. So the pathophysiology of hemodialysis induces systemic inflammatory and oxidative stress. Looking for membrane and complement associated with platelet activation and adhesion, and means that is a must in most of cases. Oxidative stress and degenerations, due to many of the mechanical effects by the blood flow or the tubing system. Also, leukocyte activations and the dual effect by activated leukocyte for both inflammation and, on the other hand, decrease attack to the microbe, so patients gain more infections. And the release of many of pro-inflammatory cytokines like interleukin-6, tumor necrosis factor, CRP, which drive many of the complications of dialysis, including anemia. What is I am very worried about during initiation of dialysis, the loss of residual kidney function, which may be the result of all through this track of inflammations and hemodynamic instability. We have different complications like brain, neurological, cardiovascular, endothelial dysfunction, atherosclerosis, frailty, malnutrition, and all. So this is illustrative diagram summarize what's behind the scene during the dialysis session, and most of them are avoidable or manageable. So dialysis and inflammations. Be aware that many cases are asymptomatic. No patient is seeing calm on bed or even sleeping during dialysis session, while inflammation is an ongoing process. So we have to look for always, although it's not in the guideline, to check for interleukin-6 or CRP pre-dialysis only in research. However, sometimes we can find that functional iron deficiency anemia by elevated ferritin and low TSAT, and this mark of inflammation we have to look for if you are doing regularly ferritin for patients. So please mark patients with high ferritin as one of the hemodialysis inflammation process. And we don't forget, and this is my publication, it was in Stockholm 2 years ago, that focus for different countries, including Egypt, Mexico, US, Italy, and others, that non-formal caregiver, the burden of the social accompanied person on dialysis. It's huge burden as well. And this is some sort of stress factor for the family. So not only for the patient health, but also for the social and the family burden, irrespective of the country. So let us start here. We have intradialytic dipping, which is acute stress, like fluid depletion, hypovolemia, hypotension, ischemic insult, tissue hypoxia, and an interdialytic climb, which is the chronic stress, including hypertension, hypervolemia, and the cardiac remodeling. So if you need to match your patients well on dialysis, we have to focus on both the intra and interdialytic periods to manage properly. So we have a paradox of maintenance hemodialysis. Although it is life-saving, however, procedure actively tips the biological scale towards the excessive production of pro-inflammatory mediators and also reactive oxygen species, and depleting essential antioxidants defenses. As I said before, dialysis is a blind technique. They cannot differentiate between what's good and what's bad, although in the molecular size. So production of oxidative stress and inflammatory mediator is a common finding. Coming to one of the big players, which is the complement activation cascade. It induced C3A and C5A. It's a well-known phenomena. During my PhD at 1990, I measured C3A and C5A during dialysis and was heroic. High activation, although at that time we are using Kiprofan membrane. However, still, during the first 15 minutes of starting dialysis, we can find a complement activations. This is terribly activate more cells like neutrophils, monocytes to produce reactive oxygen species and cytokines. We have endothelial maladaptations, and this transition from reversible dysfunction to irreversible apoptosis and necrosis. and you can find endothelial particles inside the patients. It may be physiology, toxins, dialysate, contaminants. However, the end result will include vital organs involvement, including the heart, the brain, and the gut. All systems are affected. So we have mainly complement activation and inducing neutrophil, what's called netosis, and we'll come on that induce many of the release and circulating fragmented DNA, calprotectin histones, and induce many of the organ damage on the long term of the journey of dialysis sessions. So it is modifiable disease or not? Is it a must to have or not? No, it is not a must, because if we caring well on the patients, not only on the dialysis, taking care of the vascular access, anemia management, inflammation, and infection, during the standard of care and transitioning to expand the therapy of dialysis by removing more cytokines, including hemodiafiltration and medium cutoff. In all cases, we have to use ultra-pure fluid. It is not just about clearance, it is a vital biological requirement to restore the immune homeostasis and improve the survival. And a lot of immune-mediated cytokines are released, such as larger enough by 15 to up to 50 kilodalton, and should not be removed easily, only by hemodiafiltration and medium cutoff. Thus, we standardize our therapy towards this. It is still not available in many countries, and even if it's available, it is not universal. It's cost and technically difficult. So one of the biomarker, I just memorized this paper. It was 9 years ago. I published in the Hemodialysis International and presented orally in Dallas during 2017, and it was during the microRNA gene expression in patients on hemodialysis. We have many of the microRNA, and many of them are related to end results. For example, we can have anemia metabolism related to microRNA 210. We have cardiovascular complication, myocardial injury, vascular calcification related to some types of microRNA. And in some results, it is increased after hemodialysis by a chronic state of microRNA release. And this is one of the studies that had been shown a few months ago, that microRNA release 210 is elevated, and it is related to one of the functional iron deficiency anemia with low iron, low TSAT, but high hepcidin and high ferritin. So it could be a biological marker of inflammation, and I understand it is not well spread and difficultly for measure to be a universal clinical findings. We have two types of complication, and both of them are sending to each other. Acute complication that may extend during the 72 hours post-dialysis to extend to more chronic complications. We have, during dialysis session, we may have arrhythmia, hypotension, ischemic injury, air embolism. In some cases, even if you are in chronic dialysis, we may have dialysis disequilibrium syndrome, some brain edema, especially in high permeable dialysis membrane. We can have some example of annoying symptoms like muscle spasm, cramps, hemolysis, and even pulmonary hypertension. So it's a lot. When looking for the chronic complications, usually we are focusing on the mineral and the bone disorders, mineral bone disease. Unfortunately, dialysis per se may not be a solution for mineral bone disease. Also, on the other side, we have cardiovascular complication. We have to check echocardiography finding for our patient every 6 months, because myocardial remodeling and left ventricular hypertrophy could be a clue for more complications for dialysis. So we have inflammations, we have microbial contaminants, membrane bioincompatibility, dialysate impurities, and oxidative stress. We have consequences almost for endothelial dysfunction, protein energy wasting, and cardiovascular disease. This is the end of the journey of the complications of hemodialysis. We can prevent endothelial dysfunction by proper anti-inflammatory effect. We can prevent protein energy wasting by proper nutritional support. And we can prevent cardiovascular disease by doing more stable dialysis like hemodiafiltration. And we have many of the pathway of hypotension during dialysis, intradialytic hypotension, and I think it needs a dedicated talk about that and how to prevent intradialytic hypotension and myocardial stunning. So the clinical reality of all this pathophysiological way, emphasizing that the synergy in patients with combined high CRP, interleukin 6, interleukin 8 face massive mortality risk. If we add another biomarker is a serum albumin. If we have a low serum albumin, this carries a higher risk of mortality. So we can identify many patients at high risk of complications and comorbidity. We have CRP and the pro-inflammatory cytokine act as the strongest independent predictors of all-cause and cardiovascular event. During the early 2000s, there is clothogenes and its relation to prematurity. However, uremia is now one of the progenitor model of premature aging phenotype. And this premature aging related also to inflammations and uremic toxins. So the inflammation aging feedback loop in CKD, including uremic toxin accumulations, gut dysbiosis, and the leaky period, I will come in that, cellular senescence, telomere shortening, and systemic effect of aging process, including the heart, the brain, the gut, the muscles, sarcopenia, and others. So we have here cardiac stress, arrhythmia, sudden cardiac death, hypoxemia, swinging in pH between alkalosis and acidosis. During session, there is alkalosis, and in between session, metabolic acidosis, such a pendular effect of the pH. We have solute flux. Millions of molecules are transferring from and to the blood during the 4 hours, including sharp drop of potassium, which carry arrhythmogenic effect. And our talk today about the inflammatory process. We have unphysiology, really, we have unphysiology of hemodialysis, with extreme cycling of fluid status and osmolality, with rapid changes of electrolyte and acid base. We have end-organ ischemia and stunning, and repeated extracorporeal immune system activation. In many of the uremic toxins, including and dialysis, including nitric oxide, which is asymmetric dimethyl arginine, patients on dialysis may experience low nitric oxide level, and its bioavailability is shut off, making the endothelial damage more and vasoconstriction. And we have adhesion molecules like VCAM, which are turned on thrombosis and inflammation. This is a typical diagram of many of the chemicals that had been changing during the dialysis session and even after session. The dialysis induced systemic stress of the organs, including mainly for the brain. We can find many of cases can get cognitive decline and white matter damage. Again, we have to look for residual kidney function. probably 3 to 4 milli, is equivalent to more powerful than dialysis session. Don't forget that to ask your patient about the even urine volume and take care of hypovolemia. Now it's a time to dive deeper into the molecular biology, which is the netosis, meaning that netosis is one of the degranulation of neutrophils, maybe suicidal or even degranulation alone. In comparison to foreign body, the membrane contact, they are depolarization and they are releasing and ejecting histones, myeloperoxidase, and the result is inflammatory reactions with cell-free DNA, which is known to be increased during dialysis, that drive persistent sterile inflammation and endothelial dysfunction. Just to remember the word netosis and look for netosis with different types. And this netosis, including neutrophil extracellular trap, with ruptured plasma membrane, nuclear fragmentations, and such activated neutrophil is called suicidal neutrophil because it completely release and degranulate and died. So it's called suicidal netosis and happened during dialysis also. And such during the pathway of the dialysis membrane, activated neutrophils can induce extracellular traps and release the cell-free DNA. With myeloperoxidase, elastase, and others of the enzymatic, very potent enzymatic release of the neutrophil, the finding of augmented dialysis, and may also impair the thrombosis, inducing more thrombosis and platelet activation. All of this can happen during dialysis pathway through the blood, through the membrane, through the dialysate contaminants, and almost of all these netosis is passed completely asymptomatic and the patient is not aware about that. That's called in the past hemoincompatibility, meaning that dialysis reactions by the immune system. It has a very drastic consequences, and the mortality even in the patient initiating dialysis can reach up to 25% in the first year of initiating dialysis. The complement system is sharing that in netosis and platelet activation. Yes, it's a major player of the complement reaction and can induce also by itself neutrophil activation. So we have in many patients long-standing on dialysis, they have frailty, and including in the frailty, sarcopenia, anemia, dialysis-related factor like loss of nutrients, antioxidants, intradialytic hypotension, and endotoxemia. And I will highlight endotoxemia because it's not always endotoxins coming from the dialysate. It may come from the gut by the patient. We have chemical and procedural stimuli, which meaning that fluid is not inert. Contaminants and the chemical additives continuously seed the bloodstream with micro-inflammatory triggers. Sometimes we are checking for the endotoxin level inside our unit, and the majority of units, including in Egypt, we don't check. We rely on endotoxin filter behind the machine, which may improve. However, without measurement, we cannot guarantee that it is in the ultra pure. So we have to check even once monthly. It's a very simple test and we can implement. Coagulation and activation pathway are also activated by factor 12. I studied that probably 35 years ago. The Hegman factor activation, yes, it's activated during dialysis. and they can induce more clotting. The problem of clotting is not just the clotting inside the filter. It means that there is activated clotting and coagulation pathway. Such traveling activated factors from the blood to the patient will extend the coagulopathy of the patient during dialysis. How to prevent is simply by very inert dialysis membrane and biocompatible way. It's my always favor to ask the patient how much you sleep. And we all know that sleep apnea, central and local factors are important in our patients, can induce hypoxia, fragmented sleeps, can induce pulmonary hypertension, can induce fatigue, and others. It's a common for patients on dialysis up to 30 to 40% to have some sort of sleep apnea. It may be related to obstructive sleep apnea during fluid shift during the night in patients with hypervolemia, or central sleep apnea by uremic toxins and inflammation. So we have to make a questionnaire for patients. How much you sleep? Do you sleep well? Do you are awake good? Do you feel fatigue all through the day and others? Just to pick up those who are have sleep apnea. And in particularly in patients prone for that, like obese, short neck, and other causes. We can do that in our policy is to improve the fluid to make sure that the airway are well, then refer to pulmonary units. Some patients may need CPAP or PPAP for improving the sleep apnea. I know many patients on dialysis are using such a technique and completely improve their sleep behavior. On the other hand, we can have positional therapy like 45-degree. We can treat anemia, looking for cardiac dysfunction and its threat. In studies showing that nocturnal dialysis and extended dialysis improve sleep apnea. So this is one of our missing category in patients on dialysis. Another way of inflammation is pruritus. The most problematic patients in many of them, and many of patients are not improving by intensive. It may be due to uremic toxins, mineral imbalance, nerve ending, and also cirrhosis. The first step is to hydration. Cirrhosis may be one of the manifestations of uremia. Simply patient with continuous pruritus after improving all of these factors, inflammatory disorder should be suspected. I discussed before the castor-related bloodstream infection and how it must be in good and how to looking for biofilm formation, continuous endotoxin transfer, Krebsy, metastatic infection. All of these factors also play a role, major role. By standard care, it's 10 to 15% of our patients are on the long-term catheter. If you have more than 15% of your patient in the center on CVC permicase, you have to look for additional consultation of the vascular access to improve. Coming to what's endotoxemia, we know that endotoxin is the fragments of gram-negative bacteria, and it can be in millions. The major or the famous one is the transfer of endotoxins from the dialysate. However, there is another secret is the transfer of the endotoxin from the gut. Because the gut is holding many bacteria and the endotoxins. The leaky gut syndrome or ischemic gut in patients happen during two phases. One phase is during volume overload due to edema of the intestinal mucosa, and also during dialysis session because of ischemic injury of the gut. So we have endotoxemia. By this part of my talk is under normal condition, inflammation is although protective and physiological response. However, in CKD, inflammations become maladaptive, uncontrolled, and chronic. And this my publications 10 years, exactly 10 years ago in Seattle, USA, we found that endotoxemia of patients on dialysis carries the risk of more cardiovascular disease, arrhythmia, and heart failure. And the dynamic of inflammatory markers during initiation of dialysis showing that survival cohort with initial decline of inflammation followed by sustained lower level of inflammatory biomarkers. So we have swinging between inflammatory biomarkers depending on the patient. 11% of patients died within 6 months, and in some literature up to 30%. And we understand the malnutrition inflammation complex syndrome, which is due to dialysis procedure factors, uremic toxins, gut dysbiosis. All of MEA syndrome or malnutrition inflammation complex syndrome are related totally to patients, and we can find patients with muscle wasting sarcopenia with low serum albumin. The complement pathway, all the pathways, the classical and the non-classical, the alternative pathway, are increased, inducing cell expression and enhance adhesions of neutrophils, inducing cell adhesion. Such cell adhesions can still induce leukocytes by VCAM, ICAM, and E-selectin. Damaging to endothelial is a pro-marker of vascular calcification. The inflamed aging process, as discussed, is important. And the uremic toxin and reactive oxygen species cause downregulation of activating receptor, exhausted natural killer, interestingly affecting the T cells as well. It will come on the next slide. The immune dysfunction. So what's called just a name, inflamed aging, which is chronic exposure to dialysis stress-induced premature cellular senescence. The immune system is constantly triggered by the membrane, yet become blind to actual threat like tumors and viruses. So patients exhausted his immune system cannot resist the viruses, bacteria, and cancer. And this is the story of inflamed aging, characterized by many of the symptoms we can find, like mineral bone disease, cognitive, protein energy, depression, and others. We can also define that our patients actually need an antioxidant supplementation, because we know that there is oxidative stress, there is loss of natural antioxidant. However, there is no rule up till now in the guideline to prescribe antioxidant for patients. It may be or may not be. We don't have a trial designed for that. One study was showing that vitamin E coated the dialysis membrane, and I think it's not so good because you can supplement your patient with vitamin E as an antioxidant. However, there is no rule for implementing vitamin E on the dialysis membrane. Coming to the perfect storm. We have here unphysiology of dialysis. We have retention of some of uremic toxin. If you are even doing hemodiafiltration or medium cutoff, still protein bound. We have bioincompatibility reactions, and we have contaminants from the dialysis circuit. This is the perfect storm for the patient on inflammation. Organ stunning is well known. And this organ stunning, meaning that decreased blood flow to many of the organs during dialysis, characterized mainly by myocardial stunning, 30% drop of myocardial blood flow. Also, stunning can be for the muscles, for the liver, for the gut, and for the brain. Hemodiafiltration and the cooler diastase effect improve, but does not prevent, but improve by simply cooler diastase that improves the tonicity of the vessels, and the leaky membranes in the gut may shut down. So we have to adjust many of the dialysis therapy, in particularly sudden cardiac death and arrhythmia. We have to avoid low potassium dialysate below 2. It's forbidden. We have to avoid low calcium dialysate below 2.5 milliequivalent, equivalent 1.25. Avoid large shift in volume and the dialysate cooling. Simple technique, we can prevent some of the complications. And we have dual phenotype in our patients, immunodeficiency against viruses, bacterial, cancer, and on the same side, we have chronic inflammation. Such a patient is very exhausted, very weak. We have T cell exhaustion, we have T cell lymphopenia, antibody deficiency, reduced natural killer activity by over complement system activation. And this is simply due to inflammatory condition. In studies showing that there is depleted naive T cells with impaired phagocytes and defective bacterial engulfment. Vascular access, if you look for the vascular access, inflammation, most of patients with CVC has more inflammatory reactions, even if they are not febrile or rigorous, but have some sort of biofilm formation. And the T lymphocyte precursors reduce in number and in function. We have impaired thymic output by decreasing naive T cells and reduced production of new cells. Cellular senescence with increased apoptosis. And a lot of study about how the value of CRP and others of the mortality in the research on the long-standing studying the patient for the mortality analysis. CRP and the interleukin-6 is still the golden standard to detect patients with inflammation. Vascular inflammation is another endpoint, and such vascular inflammations is manifested by some of the molecules released. And these molecules with endothelial inflammation, loss of endothelial integrity contribute to endothelial dysfunction. The hallmark, the end point of any organ damage, whatever the brain or the heart or any vessels, is the endothelial dysfunction. And in CKD, menopause disease, it transformed to a bone. Such vascular calcification and the prothrombotic state. It's called in the literature an extracellular vessels. Many types, very small, called exosomes or microvessels or apoptotic bodies. All of these are called an extracellular vessels. Such vesicles are released into the circulation. Does inflammation carry the risk of arrhythmia? Yes. Unstable left ventricular hypertrophy, remodeling, ischemic injury, rapid shift of electrolyte and inflammation carry that. We have rapid electrolyte shift, fluid overload, and cardiac remodeling. In particularly focusing for the rapid shift of potassium, swinging from hyperkalemia to hypokalemia during dialysis. And prolonged QT interval. Many studies showing that drugs that associated with prolonged QT interval, like quinolones, carry more risk of ventricular ectopy. So we have to take care about the drugs prescription to our patient, and probably an essential ECG before going to prescribe quinolones may be mandatory. And it's associated with also with uremic solids accumulation and arrhythmia, and this is typically the asymmetrical dimethyl arginine and symmetrical dimethyl arginine, and the new player, the trimethylamine in oxide. All of these are contributing for the arrhythmia and cardiovascular morbidity. We all know it's our daily practice to find that patient with ESA hyporesponsiveness, simply due to anemia, due to inflammation. And we understand that hepcidin production is one of the blocking item for the iron metabolism. And such hepcidin production from the liver is related to elevated level of inflammatory reactions. Also, inflammatory mediators directly affect the bone marrow by inhibiting iron release to the bone marrow. So in both cases, cytokines increase hepcidin, and cytokines restrict iron delivery to the bone marrow, and the final, we can find patients with high ferritin, low T-set, and not responding up to 200 micro per kg per week of erythropoietin. Typically, those patients are inflamed. And a lot of studies showing that anemia is very difficult to be treated in patients with inflammations, and many of them are related to ESA treatment and response among hemodialysis patients. The rule is not to increase the ESA because it will induce more thrombosis in patients with high coagulation profile. Is to identify first the inflammation and to treat before going to escalating the doses of ESA. Additional questionnaire, we can ask the patient about the post-hemodialysis fatigue. I usually ask the patient after dialysis. Most of patients are suffering from the post-dialysis fatigue that may extend up to 1 day after the dialysis session. And it's related to loss of nutrient during dialysis, in particular branched chain amino acid, and in another way to inflammation. So both of them can carry patients, and simply questionnaire, you ask the patient how long you feel after the dialysis session to be better. If it's 2 hours, it's good. It's 4 hours, it's mild. But for more than 6 to 8 hours, definitely patient has a problem. Pulmonary hypertension, I will not go through all of them, but I know that in Oman, Ahmed Atris and other colleagues, Professor Isa and others, implementing very magic rule, which is the ultrasound for the lung to detect the volume status, and in all the results showing that doing lung ultrasound during pre-dialysis can identify more of the volume status, both the hyper and the hypovolemic status. For the cerebrovascular, it is not immune. We have a lot of complications. We have more stroke in patients, maybe hemorrhagic and non-hemorrhagic stroke. And it's very difficult to treat patients with cerebrovascular stroke on dialysis because you need very smooth, very slow dialysis. The cause of cerebral dysfunction, again, is related to chronic cerebral ischemia and the global decrease in cerebral blood flow. The manifestation is cognitive decline, but the worst is to have typical stroke And if you have a patient with a stroke, you need to manage the patient very carefully because dialysis should be very smooth. Even you can use CRRT during the stroke. If it's not available, please shift it to PERT, prolonged intermittent renal replacement therapy, as brain edema is a must during such a state, and you have to do that very, very carefully and slowly. And the coagulation, as we said, that is not simply a clot, it's a widespread coagulation activation. And this is one of my publications. It's 3.5 years ago in the effect on the activation of the coagulation pathway. And we find that the thrombin antithrombin complex is increased more than 1.5 after dialysis, meaning that whatever the dialyzer type, whatever the mechanism. So our colleagues, what we have at the current for the management, we have to do the optimum we are currently have. Taking care by convection, hemodiafiltration, medium cutoff. Pre-dialysis serum beta-2 microglobulin is a good biomarker for mortality if it's above 25 per liter, beta-2 microglobulin milligram. And looking for more removal state of cytokines. We have to go to more flux and removal of cytokines from the body. We tested here, and it was published 4 years ago. If you are doing hemodiafiltration, I can remove a lot of cytokines, including interleukin 6. Up to 50% can be removed by hemodiafiltration. So we have a rule of removal of cytokine plus preventing its accumulation. We have also DNA methylation. This is my publication. It's probably eight years ago. Hemodiafiltration improve epigenetic changes by DNA methylation returned to back. And we can remove all of endothelial damage as a marker of serum pentrexin. The false complement trigger, the complement factor D, we can remove also by hemodiafiltration up to 52%. So we have a clearance pathway plus prevention pathway. And this study coming from Japan, they are using very superflux membrane. The mortality rate is better than in Europe or USA because they are using super high flux dialysis membranes. We have to take care about psychological and social stressors. We have to change the lifestyle, the nutrition, encourage patients for physical activity. We have to focus also on the social and financial resources, depression and the pain. All of these are not mentioned in my talk as a stress on dialysis. Increasing the dialyzer cutoff, improving the removal, expanded therapy is one of the black holes in dialysis during the past few years. Using ultra-pure fluids, biocompatible membrane, high volume hemodiafiltration and the medium cutoff, cool dialysate is cheap, cost nothing. For more hemodynamic control, supplement of antioxidants is still not on the guidelines, but may be one of our goal in some patients. Controlling hemodynamic instability, patients with intradialytic hypotension should be managed accurately and precisely, and to guide all the panoramic view of patients on dialysis, not only for the 4 hours, but also for the lifestyle modifications. Fluid, dry weight monitoring, mental health, medication adherence, dietary adjustment, regular physical activity, a panoramic care in patients on dialysis. Synergistic, all of them, including the vascular access, the treatment adherence, and salt restriction. We are looking for more of the artificial intelligence, which is really a real-time monitoring, can predict precisely fluid management, simulation, and the clinical transforming that implicate for supporting our clinical decision and preventive care. Thank you very much. I wish that this very hard topic I just highlighted as messages in my talk. I understand that every slide needs a separate talk, but just to say that we are in dilemma of problematic cases in patients on dialysis. Thank you very much, and wishing that I am not so bothering you in my very hard talk.
Thank you very much, Dr. Hisham, for an elegant, highly educating lecture. Really, you are not only nephrologist, as stated, you are an educator. You are building capacity throughout the region. But I enjoy especially the talk, but in particular, the history of your publication throughout the 35 plus years, ba'awnallah.
40
Inshallah,
years.
additional 40 years. Inshallah, additional 40 years. We aim for 200 years plus, inshallah.
Inshallah.
طبعا Dr. Hisham has nicely went through various issues of discussing the triggers, really the microvalence and systematic effects going through inflammation, oxidative stress, as well going through the actual what happened that to loss of residual volume, and of course going to the complement activation, his studies early in his years about the C3 and C5 and other sort of inflammation issue he discussed. And really he ending up with other sort of about the role of ultra pure and fluid and biocompatibility, and going through various sort of inflammation, malnutrition, its roles, and how the chemical and procedures as well stimuli leading to many clinical disorder in our patient, include sleep disorder, in addition to pruritus and so on, and then ending up with the cube of management and the 3D sort of issue we need to do. Of course, I will go through the question. I think the first question really come from Dr. Seja. Seja, are you online still? You want to state that directly, Dr. Hisham?
السلام عليكم. Thank you, Prof
Saja.
Hisham. كيف الحال? Thank you. It was very excellent presentation and very comprehensive
Thank you.
lecture. I think in chronic dialysis patient, we are like missing to take care about the oral hygiene, and like oral or periodontitis, like or infection or oral infection, it is not part of screening in chronic hemodialysis patient.
Yes,
While
excellent,
it is
Saja. Yes, excellent.
yeah, while in transplant like workup we are considerate, but in chronic dialysis not.
Yes, I fully agree that oral hygiene is one of the trigger of inflammation. And if you look for our patients, no one just asks the patient to open his mouth. So
Yeah, exactly.
even they are looking only for telescope division for the vascular access, maybe. But to open his mouth, yes, I fully agree. Yes, very good notice that we can add this step also in our physical daily practice.
One more question about like one of the like now there is like increasing like evidence that omega-3 use to reduce the chronic inflammation in dialysis patient. So what's your opinion about like routine use of omega-3?
During my guidelines, I published 2019, which is a very extensive guidelines, are searching for that. There is no, still, some of the trace elements are looked for example, zinc and others. No sharp guidelines, even are prescribing more L-carnitine and improving the muscles and mitochondrial function. There is no guidelines to say. I don't give my patients omega-3. I encourage more protein intake. I encourage more salt avoiding, and encouraging not too much potassium. And do you know that many of the essential minerals are present in the vegetables and the fruits, and many of our patients are restricted. So for giving omega-3, I don't mind if you are giving or not, but there is no guideline to say that we have to do.
What about the probiotics?
Yes, probiotic, this is another excellent one. You know that many of the endotoxins I highlighted are just focusing that endotoxin, we are looking for endotoxin for the vascular access and the water. Sometimes it's internal endotoxemia in our
Yes.
patient from the gut dysbiosis. And at that time, yes, I agree to give the patient a probiotic.
And this is like one course, or yeah, how frequent we are giving, and there is any.
Sometimes you are giving at the start of every month for a few days.
Okay, tamam. Thank you, Prof.
Thank you very much.
Thank you, Sajid. Dr. Ibrahim Al Sayed. Ibrahim, are you online still about your question? Dr.
السلام
Ibrahim?
عليكم ورحمة الله وبركاته. Thank you. السلام عليكم ورحمة الله وبركاته. I am with you, inshallah. Thank you, Dr. Hisham, for this يعني just very informative floods of informations. Thank you very much for this presentations. Just احنا on daily practice we are facing this difficulty with other specialties, especially for our dialysis patients who are dialyzing at hospital-based dialysis units. They have to prepare them for endovascular procedures, any type of surgery, think of a lot of issues under GA especially. The majority of them, they have highly chronic inflammation, CRP more than 100, almost all like this. For surgeon or other subspecialty are rejecting the patient, please optimize. طبعا are facing difficulty to optimize such situations. Even we cannot, we try to rule out any kind of sepsis. We just inform this is as a part of chronic inflammation of dialysis. But just what's your advice to prepare a patient for any kind of interventions to minimize such inflammatory markers and this oxidative process? That's my questions.
Thank you, Ibrahim. I can see that you are standing in the corner. You cannot do something for your patient, and they are asking to do a lot of you for your patient, so you don't have something. Please
That's
be
right.
informed that CRP is not dialyzable. So again, it's Procal. Procal, in my research, I published that procalcitonin is dialyzable. So if you are measuring Procal before and after dialysis, you can find up to 45 to 50% drop, but reaccumulate by inflammation. CRP does not do such a scenario during dialysis, and it lasts a long time. If you have a patient with very high CRP, look for the vascular access, the first part. If you have an arteriovenous graft or a catheter, be sure that it is a biofilm. If the patient is still using arteriovenous fistula and no obvious, come to Saja, highlighting very important point about the mouth hygiene. If you cannot find, do different blood cultures. And sometimes I still have one patient was during my last week with candida in the blood culture. So I think we have to look thoroughly for patient with where is the hidden infection, which is usually on that. If so, don't rely on CRP because it drops very slowly and takes many of the time. Provided that the patient has CBC with a normal, hemoglobin is okay, ferritin is not so high. So it measurable that CRP is a measure, yes, but other is also important. If you find all of them, you have to do, even I did once for patient with PET scan to find where is the infection.
Okay, that's enough. Usually I'm asking just to do online infiltration, pre-dilution mode, at least prolonged session before any kind of surgery. I think it will give some benefit.
Yes,
Procedures.
as I highlighted that convection therapy is a good tool.
Yes.
You can remove 60% of interleukin 6. You can remove a lot by hemodiafiltration. of inflammatory mediators, complement factor D. You can remove kappa and lambda. All are triggering factors for inflammation. So definitely, hemodiafiltration, cooler dialysate is one of solution you apply.
Thank you very much.
Prof Hisham, regarding you are working in Muscat about a study regarding EPO resistant. We collect about 90 patients from 270, يعني about 35% of dialysis center have EPO resistant. When we investigate the cause of EPO resistant, we found mostly is inflammation.
Yes, sure.
We take some patient from this study and doing intensive dialysis, prolonged intermittent, as you learning us, prolonged intermittent dialysis. We give some of them long dialysis session about 6 hours. We found a change in the inflammatory markers, and most of them decreased the EPO resistant. I think برضو الانتنسيف dialysis or prolonged intermittent dialysis can help in remove inflammatory markers.
If you are using a good permeability membrane, superflux, or just to be sure that cytokines by size are removed by dialysis. So prolonged and convection and permeable dialysis, like in Japanese way, they are using very high permeable dialysis membrane. So all of these are one stone and many birds you can do.
Thanks, Prof.
All right. Dr. Ula, she has a question. Dr. Ula, Rula Uthman. تفضل دكتورة.
Rula
If you
from
are...
Mecca.
Yeah.
السلام عليكم.
وعليكم السلام. أنا رولا.
ازي حضرتك، ازي حضرتك وفضل الدكاترة الأفاضل. هو أول سؤال سألته دكتورة ساجة، كنت بسأل على البريبيوتكس والبروبيوتكس وحضرتك جاوبتني عليه يا دكتور هشام. هو النقطة إنه في study طلعت من حوالي شهرين تقريبا كانت بتتكلم على، يمكن ده يبقى شوية out of the scope المحاضرة، على الأوزاريس فلتر والإفيكاسي بتاعته في حالة السبسس even لو العيان مش في acute kidney injury. كنت عايزة أسمع رأي حضرتك في الموضوع ده. طبعا كانوا بيتكلموا على إنه سايتو أدزوربنت وعلى إنه هيقلل الاندوتوكسنز والكلام ده كله، فكنت عايزة أسمع رأي حضرتك في الموضوع ده. وفي حتة تانية كنت عايزة أقولها في الدكتور اللي قاله دكتور في الجزء اللي قاله دكتور أحمد من شوية، لأنه دي كانت رسالة الدكتوراه بتاعتي. لو في functional iron deficiency فعلا إحنا كنا يعني لما زودنا الغسيل وفعلا كان على hemodiafiltration وconventional ده جاب نتيجة. بس طبعا لو العيان رجع تاني بعد كده الأمور بترجع تاني، لازم أعالج الكوز نفسه، يعني
طبعا
لازم أدور على الكوز. يعني هل هي فانكشنال نتيجة ليفر ديزيز مثلا كان عند العيان، هل هي الدوز بتاعت الايبو اساسا مش مظبوطة، هل في سورس اوف انفكشن لسه ما زال مستمر موجود عند العيان. فدي كلها فاكتورز الى جانب ان احنا نحسن الدياليسيس بتاع العيان. والله اعلم طبعا. وشكرا ليك يا دكتور هشام، شكرا لدكاترتنا الافاضل يعني على المحاضرة الرائعة دي.
Thank you, Rola. For your first question, cytoadsorption, I don't believe in that. Because there is very expensive, does not remove except the target molecules. Even if you are using CRRT, using the very expensive Oxalis filter for endotoxin, it's a very simple. Dialysis is a very simple. If you need to remove cytokines, you can do hemodiafiltration, medium cutoff simply. You don't go to cytoadsorption and pay thousands of money for that. If the patient is hemodynamic and stable, and acute kidney injury, you can do CRRT. Whereas the adsorption technique, I think it is not so common to be used in our practice worldwide. For your first question. For the second question, yes, inflammation can increase as highlighted, the hepcidin from the liver, blocking iron metabolism, and also directly the cytokines on the bone marrow, inhibiting iron delivery to the bone marrow cells. So improving the inflammation while doing dialysis, again, you have to use a high permeable dialysis membrane with prolonged. You cannot use prolonged dialysis with low flux or just simply low permeability filter. So be sure that I confirm that by my study. You can remove 56% of almost all the cytokines by this technique.
تمام. ممكن أسأل سؤال تاني بعد حضرتك دكتور؟ بالنسبة للسؤال دكتور أحمد عن السيري أكتيف بروتين لما يبعت الحالات ويرفضوها لغاية ما يظبط. طيب وقلنا البوكال ممكن أتابعه طبعا وأكشف على العيان وأعمل له ويل أسسمنت. الانترلوكين 6 لو متاح عندي، لو مش هيكلفني، هل ده ممكن يفرق معانا في الدايركشن ولا لأ؟ إن أنا أقيسه وأشوف الوضع إيه؟
You remember our discussion,
أيوه.
alhamdulillah, 6 years ago?
أيوه.
During the COVID era, and you catch me in the center. I was so afraid from the COVID, and everyone is calling me for a COVID. I am in a very closed room and thinking that even our phone call will transfer. You are calling me from the ICU, and I put a mask while you are calling by mobile for that. Yes, interleukin 6, yes, we measured here interleukin 6 for the storm. But actually, in the physiological pathway, when you have inflammatory cytokines, interleukin 6, you have against anti-inflammatory cytokines. The problem is to neutralize the inflammation. However, in the storm, the inflammatory cytokines is rapidly increased, so the anti-inflammatory cytokines cannot. If you are doing heme adsorption, you are removing both the inflammatory and the non-inflammatory or anti-inflammatory cytokines. You are removing many of them. So if you are measuring interleukin 6, you have the facility, yes, you can do it, and you can remove it. You can measure pre and post dialysis as well. So it's a good tool. Yes, it's a good tool, but not available in all centers.
تمام يا دكتور، تمام، تسلم، شكرا يا دكتور. Thank you.
Thank you. شكرا رولا. I don't know whether Dr. Fatma Mahmoud, I think she has a comment if she'd like to state it. Otherwise, Dr. Fatma Mahmoud. I saw only she mentioned about precaution, Dr. Hisham, during hemodialysis in patients with high-grade glioma, which you mentioned few of those precautions already.
High-grade glioma.
Yeah.
We have to do it very, very smoothly, dialysis.
Yeah.
We have to extend the dialysis like prolonged intermittent renal replacement therapy or CRRT. Because brain edema, one of the major indications for CRRT is increased intracranial pressure. So if you have increased intracranial pressure, if you have CRRT, go with CRRT. If you don't have CRRT, go with 12 hours per technique.
Yes. All right. Saja, do you want to say something else? And see you posted another comment.
Yeah, Assalamu alaikum, Prof. Isa. Thank you for allowing me to ask again. Prof. Hisham, we are doing like as monthly lab in chronic dialysis centers. We are for the inflammation is the C-reactive protein, the routine one. We are not using the high sensitivity C-reactive protein, which is more, I think, sensitive to chronic inflammation, not acute inflammation. So I don't know why we are not using the high sensitivity C-reactive protein. So you can answer me or even Prof. Isa. Thank you.
Professor Isa is the master.
Not at
You
all.
respond.
It's all about cost and containment, especially nowadays. Nothing more or less, really.
But in general, very few countries who are following up their patient by CRP. We don't do it here. Even in the excellent centers. And even in many of the European countries and US, they are not measuring CRP as a routine. So if you are using that CRP, even not high sensitive, you are one of the pioneers.
In fact, our colleagues, the head of Department of Infectious Disease, say you people ordering a lot of CRP. What is the purpose? What are you going to achieve? And
I think it's not routinely, yes.
Yeah, which we usually do routinely, but they are questioning nowadays because they're trying to reduce the actual laboratory we order and the cost.
I think serum albumin level is very simple testing, giving more value than CRP. And if the patient with low serum albumin below 3.6 gram per deciliter, you may proceed. If it's above, the patient nutritional status is good and inflammation status is good. Very simple technique and more of value for the mortality and the morbidity serum albumin. So you can do it every month.
If anyone has any
It
question
is
or
great.
comment,
I need to add something. Sorry, I need to add something. Usually, pre-operative, intraoperative, post-operative, we sometimes are doing, but not almost always, about اللي هو inflammatory optimization bundles. You get my idea? Some like validated score before you are going to surgery. So usually we involve the CRB, ferritin, the serum albumin, the nutrition status, something like this. We try to do extended dialysis before the surgery or before the intervention. Are considering CRB one of this bundle, but not almost usual with all patients, just only patient prepared for any kind of surgical intervention or something like this.
Yes, on the smaller scale, you can. The problem is not to identify, as you say, that high sensitive CRP is more informative, and it's just giving a way to look for more in depth, to dive more in depth. So it's okay for a selected patient, but for general dialysis population, I don't think that all centers are doing so.
اوكي. واخيرا ليس اجل واعظم من ينشئ انفسا وعقولا، ودكتور هشام جزاه الله خير دائما يمتعنا ويسعدنا. وفعلا كثير من زملاء الدكاتره هم يعني طلبه وتعلموا واصبحوا اساتذه بفضل دكتور هشام، فجزاك الله خير الجزاء دكتور هشام. والامر ناو موصول لاخي الزميل دكتور احمد عتريس للكلمه الاخيره. تفضل يا احمد.
الله يكرمك، جزاكم الله خير يا بيه، ودايما بتشرفنا دكتور هشام وبتنورنا والزملاء الاعزاء. ونختم ان شاء الله. سبحانك اللهم وبحمدك، نشهد ان لا اله الا انت، نستغفرك ونتوب اليك. بسم الله الرحمن الرحيم. والعصر ان الانسان لفي خسر الا الذين امنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. جزاكم الله خيرا.
جزاكم
شكرا
الله خير.
جزيلا
شكرا
اخواتي كلكم يعني، ونشوفكم دايما على خير باذن الله تعالى.
ان شاء الله. تسلم يا
مع
هشام.
الف
شكرا
سلامه
حبيبي.
ورحمه الله
مع
وبركاته.
السلامه. مع السلامه.